Hi, everyone. It's a pleasure to be here. I'm Dr. Stephanie Reyes. I'm one of the neurology resident doctors at Duke University Hospital. I'm in my fourth year of training going into general neurology, where I see patients in the hospital and in the clinic and manage most neurologic conditions without a particular specialty. Mucho gusto a todos. Soy la doctora Reyes. Estoy entrenando para ser neuróloga. Estoy en mi cuarto año. Casi termino. Voy a ser neuróloga general. Entonces voy a ver pacientes en el hospital y en la clínica igual. Y hoy voy a presentar sobre el dolor de cabeza, pero voy a presentar en inglés. So what I'll do is I will share my slides. I just have a few slides to share with you all.
And I'm sorry, Dr. Reyes, I just want to remind everybody, an interpreter had an announcement to be sure that you select the icon of interpretation according to the language that you want to listen the presentation. Por favor, escoger el idioma que ustedes quieren escuchar la presentación. El icono está en la barra de abajo. Si eres nuevo, no conoces el sistema. Dicen que no se escucha bien. ¿Pueden escuchar a la doctora Reyes?
Sí.
Ok.
Perdón, ¿quieren que hagan el anuncio?
Por favor, sí.
Sí. Muchísimas gracias, doctora Rosa. Mi nombre es Cristian Restrepo y estoy aquí para colaborarles con la interpretación simultánea. Si ustedes están en un computador, puede seleccionar el botón que dice interpretación en los controles que están en la parte de abajo de su pantalla y elija español. Si tienen una tableta o un celular, haga clic en los tres puntitos en la esquina inferior derecha de su ventana Zoom, luego en interpretación de idioma y después español. Si no selecciona un idioma, no podrá escuchar al intérprete cuando hable en su lengua. Que tengan mucha suerte. Ahora voy a decir las instrucciones en inglés. Good morning to everyone. Good afternoon, sorry. My name is Christian and I'm going to be your interpreter today, and I'm going to give you some short instructions on how to use interpretation. So if you have a computer, click on the globe-like icon that's at the bottom right of the Zoom window, then select English. If you have a tablet or a smartphone, click on the three dots at the bottom right of your Zoom window, then on language interpretation, then on English. Please remember that if you do not select the language, you will not be able to hear the interpreter. Thank you very much, and back to you, Stephanie. Break a leg.
I'll try not to. So today I'll be talking about headaches. And we'll start off by mostly talking about migraine and a few brain bleeds. So what's important to know about headaches is that there are actually over 200 headache types that exist. Most people don't think about it or know about it, but there are so many headaches. And the majority of the headaches are actually very benign, which means that they're not going to cause any life-threatening issues. It's not an emergency. It's something that needs to be treated, but oftentimes can resolve over time. So that's the majority of headaches. But there are a subset of headaches that could be very dangerous if they're not addressed or recognized urgently. So that's why it's important to try to understand what headaches are more normal, benign, you'll be able to treat at home, and what headaches might be concerning that might require you to seek medical attention quickly. And migraine is actually the most common benign type of headache. So I'll talk about what it looks like and how it's treated. And then for a little bit of time, I'll talk about brain bleeds, because that's the type of headache that needs emergent evaluation, or it could be life-threatening. So moving on to migraine, characteristics that we think about for migraine is that it actually has to be very painful. So there are mild headaches that we can get that are often tension type headaches that you can work through, still go to work, still do chores at home. You feel it, it's in the background, but you're able to keep working. Migraines, however, are slightly more disabling. So they tend to be moderate or very severe, where you're no longer able to do the things that you were hoping to do that day. And so the intensity of the headache is usually a lot worse. It's usually unilateral. but it could be the whole head, it could be the top of the head, it could be the back of the head, it could be anywhere. It's just that the majority of the time we see it on one side. And then characteristically, it's pounding. So it feels like someone's hitting you persistently at that spot where you're feeling the pain. In contrast to that, though, sometimes migraines can just feel like a really, really strong pressure, almost like you feel like your head's going to explode because the pressure is just building and building. So it could feel a little different, but most often folks will say that it's pounding. In addition, you can also have sensitivity to light and sound. And this is what's a little bit more special about migraines. Other headaches don't typically have this association. What I mean by sensitivity is if you're having the headache, if there's a loud sound in the background, you feel like the headache is getting worse or it's intensifying. So you want to try to go into a quieter place to try to feel better. The same is true of light. So if you're outside, it's shining bright, you feel like your eyes are straining and the headache is getting worse from the bright lights. That's a very classic migrainous feature. A lot of other headaches don't have that. So if you have some of these characteristics, start to think, oh, I might be having a migraine, or my loved one might be having a migraine. Nausea is also a very common characteristic of migraine. However, nausea can be seen in other headache types that could be dangerous. Not to say that if you're nauseous with a headache, you should be worried, but it's something to think about. If you're having a headache that's concerning to you or is different than the headaches you've had before. Lastly, movement usually always makes migraines worse. There are some headaches that moving around makes it better, but universally with migraine, the best you feel is when you're sitting or standing or laying still. That's how you get a sense of this is more likely a migraine. If your headache is telling you that you want to move around and keep doing things, it's likely not a migraine. And then lastly, I want to talk about aura. And so with with migraines, you can sometimes not have the pain at all, which people are surprised to hear. Sometimes what we see is that folks will develop migraines, let's say early in life, in their teens and 20s, especially young women, after they've had their menstrual cycle, their first menstrual cycle. And then over time, they might start to they might start to have pregnancies, different hormonal changes that causes them to have resolution of their migraines. But then later in life, after menopause, typically, they'll have a reemergence of their migraines, and it'll be in the form sometimes of just an aura. So early in life, you might have the classic migraine, pounding pain, nausea, sensitivity to light. And then later on in life, you might just have an episode of vertigo where you feel like the room is spinning for 2 hours, maybe 1 hour. You don't feel well after. That can actually be a migraine aura or your type of migraine. Or you can have vision loss where it's most often in your periphery, where you start to have blurry vision on the sides, maybe one eye or both eyes. Or you can have spots in your eyes, in your vision, and they typically last 15, 30 minutes. Shouldn't last hours. That would be concerning. But it'll last 15 to 30 minutes, maybe 1 hour at most. And then that might follow a headache. So that might be your sign of, oh man, I'm probably going to get a migraine because I'm having these visual changes. Additionally, you can also have numbness and weakness. And so some patients with migraine can be paralyzed on one side where they can't move their arm and leg, and it can actually look like they're having a stroke. In that case, you should go to the emergency room because you could be having a stroke. But it could also be that after the development of that weakness, you start to have the headache. And after doing the studies in the emergency room, come to find out everything is fine, and it's like likely your migraine. That's very rare, but it's possible, and we see it from time to time. And lastly, migraines very common. 1 in 10 people in the world will experience a migraine. And so even in our group, there's a high chance that 1 to 2 of us will have had a migraine in the past. And in different scenarios or different circumstances, that probability is a lot higher because more young women will experience migraine compared to older men, let's say. This slide is to highlight how disabling migraine can be. For those who have not suffered from migraines, they're always surprised to hear that someone who's having a headache is canceling an appointment, doesn't want to go to a party, can't come into work. They always say, "Oh man, it's just a headache. Just take Tylenol. Just you'll be fine." But actually, for those who are having a fairly severe migraine, when we've compared it to other diseases in terms of how disabling it can be, if you notice, migraine is actually seen as more disabling as having a heart attack in comparison, or could be as disabling as severe dementia or severe anxiety, which is shocking because those conditions are seen as very disabling, not being able to function in the acute setting. But migraine is there alongside those. That's how disabling it can be for someone. And what's important to mention is that there are disparities in how often migraines are recognized in certain groups of people. And it's most severe among Latinos and African American and other Black communities. So for Latinos, 50%, they're 50% less likely to receive a migraine diagnosis compared to whites. And it's been studied in the past. And there are some theories surrounding lack of recognition of pain and this understanding that minority groups might experience pain less so or can deal with pain less or more often than other groups, which is clearly not true. And so that's one of the reasons why it's under-recognized, because pain isn't seen in the same way. But that's why it's really important to understand that if you know what migraine looks like and you feel like you're having a migraine or your loved ones are having it, it's important to seek help so that it's recognized and it's treated so that you don't have to suffer from the disability of it. So common migraine triggers. Caffeine withdrawal is a very common one. So if you suffer from migraine, the best thing to do is to not drink any caffeine at all. But if you are going to drink caffeine, be consistent. So if you're drinking a cup of coffee in the morning every day, do that every day. The moment that you skip that cup of coffee that day, it's almost like 100, I'm almost 100% sure you will have a caffeine withdrawal migraine. And it's because your brain is used to a certain amount of caffeine. And once you eliminate that amount of caffeine, your brain is like not imbalanced anymore in terms of the caffeine that it's used to getting. And so in that instance, the best thing to treat the migraine is actually to drink a cup of coffee if you can. Other common triggers are dehydration, lack of sleep, stress. These are all things that affect your brain health. And so for your brain to be able to work optimally, you have to be drinking enough water throughout the day. You have to be sleeping at least 6 hours every night. And really it should be 7 to 8, but you should make sure you're sleeping at least 6 hours. And then managing stress, because if you're not managing stress, that will always manifest into symptoms that you feel, whether it's migraines, aches, pains, fatigue, weakness. And then other common triggers are alcohol withdrawal, so that hangover headache that you get if you've drunk too much alcohol. Eye strain, so if you really are in need of glasses, you're having trouble with vision, that type of eye strain can trigger a migraine. Uncontrolled blood pressure is also a very common trigger, because if you're having so much blood flow to the brain because the blood pressure is so high, that in itself can trigger the process of a migraine because your brain just isn't used to that amount of pressure. And then hormonal changes. So pregnancy, menopause, drugs that affect your hormones in any way can trigger it. And then This is somewhat of a busy slide, but I just want to share with everyone the treatments that are out there. There are so many treatments, probably close to 100 medications that you can potentially try for migraine. And it's split into two categories, abortive and preventative. And abortive just means if you're having the migraine, this is a medication you take to relieve that migraine. Preventative is when you're having so many frequent migraines that you want to take a medication to try to prevent another migraine from starting. So for abortive therapy, if you're having migraines, first line is over-the-counter medications. So try to take Tylenol, try to take ibuprofen, rest, drink water, caffeine if you haven't had your cup of coffee. That's the first line. If that works for you, that's all you need. Don't have to worry about any other medications. If that doesn't, that's when you seek out help from your primary care doctor or a neurologist, and they will offer you medications that were designed for migraine. So triptans is a class of medications. There are at least 11 drugs in that class that are meant only for migraine. So it doesn't help with any other pain. It doesn't affect your heart, your kidneys, your lungs, your liver. It doesn't have any organ dysfunction because it's strictly made for treating migraine. So it's very safe. And it's very effective. I can tell you a personal story. I suffer from migraines. My mom does, my grandmother does. And for a very long time, Tylenol, ibuprofen didn't really help, and I would struggle at work. And the moment I started rizatriptan, I have been able to take that medication, not get migraines, and be able to keep working. So it's been life-changing for me, and it can be for anyone. So there's really no reason for you to have to struggle from having even occasional migraines. You should have something that's going to work for you, like very efficiently, or seek that at least. And then there are third line medications that are very new, expensive, that I wanted to just let you guys know are available. We see a lot of commercials about this, but it's cost prohibitive. And for your insurance to cover it, you'd have to work through some of the triptan medications. And then very quickly on the far side, these are some preventative therapies. And there are many, many you can try. And if you're having a lot of migraines, talk to your provider because there are some medications that you can take to help with a different condition you might have. So there are medications for high blood pressure, like propranolol, that can help also manage your migraines. If you're having a lot of pain, amitriptyline can sometimes be used for neuropathic pain, but it can also help with migraines. And so there are a lot of first-line medications that a lot of people can take anyways for other reasons that can also help with migraines. And then I mentioned these second and third lines, which require you to see a neurologist to talk through whether you're eligible for these, but there are these new injectables that are just once a month. You just inject it once a month and it can help prevent migraines, at least 50% of your migraines. So you only need to take 12 a year, which is very convenient, and can be affordable if you've tried other things. And then Botox is also something we can offer. And then I will end with brain bleeds. So brain bleeds are a rare cause of headache, but we see it fairly often in the hospital because patients arrive very disabled by it. So I would say there's not a day that I work in the hospital where someone does not come in with a small brain bleed. If you can imagine, sometimes we get a few in a day. And if you can imagine, there are different spaces around the brain and within the brain where blood can enter. And the blood is coming from the arteries and the veins that are going up to the brain to try to give all those nutrients and oxygen that the brain needs. The most serious of the brain bleeds that we worry about is called a subarachnoid hemorrhage. And a big percentage of the people who have this type of brain bleed, they have it from an aneurysm, which is essentially a weakening of the wall of an artery. that causes that area to expand. And every time blood flows through, some of it enters that area and keeps pushing on that weak portion of the wall. And over time, it'll expand so much that it can burst and cause blood to come out. And it'll usually surround the brain. And that will affect other arteries in the area and irritate those arteries and cause it to spasm or stiffen up, and can result in strokes, seizures, eventual coma, and then patients can pass away if it's not recognized. And this can happen within hours of the bleed, days or weeks. And the way to, or what to think about or when to think about this is someone who doesn't typically have headaches, and then they suddenly have a 10 out of 10 headache, very severe. They've never experienced that kind of pain before. It came out of nowhere. It's very sudden onset. When that happens, they have to go to the emergency room. It could be nothing, but it could be a subarachnoid hemorrhage. So it's important to go immediately if that happens. And then these are 3 other types of headaches or brain bleeds. These 2 happen typically from trauma. And so if you imagine hitting your head, there are veins and arteries close to the skull and the brain that can burst. And as the blood is expanding, it's pushing on the brain and again can cause seizures, stroke, and eventual death. And then of these brain bleeds, the most common is a bleed that occurs within the brain. It's called a intracerebral hematoma. And the most common reason for this is uncontrolled hypertension. Hypertension is very common. But if you have long-standing high blood pressure that you haven't been able to control with your diet, lifestyle changes, or medications, that amount of pressure of blood going into the brain can cause very small arteries to burst. And then you have a pretty massive brain bleed that will inevitably cause you to have a stroke. So you can end up being paralyzed on one side or even progress to death if it's severe. Other risk factors include smoking, a family history of aneurysms, illicit drug use like cocaine, and then for patients who drink a lot of alcohol, over time, a lot of alcohol can cause your brain to shrink faster than other people. And so because of that, you're at risk actually of developing dementia more quickly than you would have. And then also because your brain shrinks, there's more fluid around your brain. And so if you hit your head, there's more of a whiplash, you could say, or more space to develop one of these brain bleeds. And so if you're an alcoholic or you drink a lot of alcohol and you fall, hit your head, especially if you're older, that could potentially result in a brain bleed, and you'll develop a headache, but it oftentimes will be mild and then increase in intensity over time. And if that's the case, you should really go to the hospital and seek evaluation at that point. So those are the worrisome types of headaches that we worry about the most. And that is actually all I'm going to share for today. There's so many headaches, but I think these 2 classes are probably the most important for everyone to understand and think